Hi guys, this presentation will be on obsessive compulsive disorder, the diagnosis, history, exam, investigations, and treatment. Case presentation. Mike is 31 and for years he has been afraid that electrical appliances, if not switched off, could lead to a fire and harm his family or neighbors. He spends 4 hours a day checking that such dangerous appliances are safely switched off. What is the likely diagnosis? Design a graded exposure and response prevention program for him. So your differentials for this patient, provisional diagnosis is obsessive compulsive disorder. Differential diagnosis could that he has psychotic illusions, that he has delusions that he turned off or turned on his kettle. He has a mood disorder. Major depression can often result in patients ruminating or having obsessions as well. Or he could have hypochondriasis because of his fear of health and fear of it being contaminated as to why he's so obsessed about it. The DSM5 criteria for obsessive compulsive disorder as the presence of obsessions, compulsions, or both. It's no longer an anxiety disorder. So obsessions are recurrent or persistent thoughts, urges, or images that are intrusive and unwarranted. This causes significant anxiety and distress. Compulsions include repetitive behaviors such as ordering, checking, hand washing. Mental acts such as praying, counting, or repeating words. The compulsions or behavior or mental acts is aimed to reduce distress, but are not always realistically neutralizing or preventing what they are meant to address. In terms of typical obsessions and their related compulsions, many people have a contaminated obsession, and this results in them repetitively hand washing or cleaning. If they have a safety obsession, they become repetitive in checking and ensuring a lock is locked an X amount of times. If they have a religious obsession, their compulsion is repetitive prayers. So compulsions can either be behavior-based or mental-based, such as mentally repeating or visualizing phrases. In terms of a history, what you want to get from them is the symptoms of the obsessive compulsive disorder, a risk assessment for any psychiatric history, and risk factors for obsessive compulsive disorder. In terms of symptoms for obsessive compulsive disorder, you want to ask about the nature and severity of their obsessions. For example, have you ever been bothered by your thoughts that do not make any sense and keep coming back to you even though you try not to have them? When you have these thoughts, how would you try to get away from them? The nature and severity of compulsions. Has there ever been anything which you've needed to do repetitively over and over, like washing your hands, counting up to a certain number, checking something several times to make sure you've done it correctly? It's important to ask how obsessive compulsive disorder has affected their social, interpersonal, financial, and legal lives. You want to screen for comorbid symptoms such as a psychotic disorder, mood disorders, impulse control disorders like kleptomania and urge to steal things, or anxiety. The risk assessment, you want to assess their risk to self, others, reputation, and suicide. And in particular, obsessive compulsive disorder causes patients to have a high risk of suicide, so it's very important to ask this. In terms of risk factors for obsessive compulsive disorders, a past psychiatric history such as mood or anxiety disorders, ADHD, tic disorders as a child can predispose patients to having obsessive compulsive disorder, as well as a family history of any mental illnesses. In terms of suicide and obsessive compulsive, they're at a high risk of suicide because the obsessions and compulsions are so distressing to them. They do the compulsions because of how anxious their obsessions. So patients with obsessive compulsive disease don't think that they're normal. They actually regard their obsessions and compulsions as irrational, and this leads them to believe that they themselves have a problem. However, unlike a depressed person, they believe ideas of worthlessness and accept it as part of them. So depressed people are actually less likely to suicide than those with obsessive compulsive disorder. On examination, you want to do a complete mental state examination. Physical examinations with obsessive compulsive disorder are useful, and the Yale Brown Obsessive Compulsive Scale. So in terms of physical exams, you can look for eczematous eruptions from excessive washing of their hands. They have hair loss from excessive hair pulling, excoriations from compulsive skin pricking. In terms of the Yale Brown Obsessive Compulsive Scale, YBOCS, there's 10 items, 5 for obsessions and 5 for compulsions, and they're given a score of 0 to 4. It's a good baseline tool to determine patients' response to therapy. And the next slide may seem a little bit intense, but it just outlines some of the questions that they have for obsessions and compulsions. And there's actually more than 10, but you only mark 10 of them. So there are 19 items rated actually, and only 1 to 10 are used to determine the total score. So 5 for obsessions. How much time is occupied by the obsessive thoughts? What is the longest number of consecutive waking hours per day? Are you obsession free? How much do your obsessive thoughts interfere with your social work functioning? Is much distress due to your obsessive thoughts? How much of an effort do you make to resist these obsessive thoughts, and how much control do you have over these obsessive thoughts? Then you give them a score of 0 to 4. And this one is only an example for the first question of time, with 0 being none and 4 being extreme, greater than 8 hours a day, or constant, which is occupied by the obsessive thoughts. In terms of compulsions, again, it looks at time, the compulsion-free interval, but it also looks at the interference due to compulsive behaviors, distress associated with compulsive behavior, resistance against it, degree of control over compulsive behaviors, insight into obsessions and compulsions, and whether they've avoided doing anything because of their concern of how they'll perform with their compulsions. Do they have indecisiveness? Do they blame themselves for the outcome of events that are not entirely in their control? Do they have inertia, whereby they have difficulty starting or finishing tasks? Do you doubt whether you have performed the task correctly? And then at the very end, the interviewer also has 3 questions, which they rate 0 to 4, which is the perception of how severe this is for the patient, how much they've improved since the last time they've seen it, and how reliable are the findings for this patient. So the next one is, so once you finish your differentials, history, and examination, you want to devise a formulation for the patient's disease, assessing the presence of predisposing, precipitating, perpetuating, and protective factors. In terms of management, this can be divided into different stages. So it's important that all management is multidisciplinary and it uses a biopsychosocial model. The first line of management is psychotherapy, which includes education, cognitive behavioral therapy, which is often with graded exposure and response prevention program. The second line is pharmacotherapy, and SSRIs are their first line. And if they have severe obsessive compulsive disorder, have a very high suicide risk, or they're so disabled that they have no self-care, you would want to hospitalize these patients. In terms of the psychotherapy for obsessive compulsive disorder, you want to include both the patients and the family. Educate about the family and the patient about their condition and what can be done about it. And then move on to cognitive behavioral therapy using an integrated exposure and response prevention program, which we'll talk about next. So the aim of this is to expose the patient repetitively to cues that provoke their rituals. And then there's a strict response prevention. So don't let them do the rituals such as turning off the kettle that reduces their anxiety. For this patient that we saw at the beginning of this slide, we'll just go through an example of how we would do that for him. So first, you want to ask him what his fears are, and ask him to list them from least to most threatening. You want to start with the least threatening. For example, his obsession with not burning the house down by leaving the iron on, and so he has to check it numerous times before it's turned off. And then you would go into a realistic scenario, and then turn on the iron, and then ask him to turn off the iron once. And then if he usually leaves the house, we leave the house together, and then you stop, preventing him from turning off the iron 2 or 3 times. And you want to talk with him through the ways of coping after he's turned off the iron once, rather than checking it a number of times. So this is 1 to 4 is how you would do one scenario. And so you want to keep repeating this, and each time you do it, you want to increase the threat. For example, maybe add in more appliances, maybe iron and microwave, or iron, microwave, and oven, for example. And the aim of this is to remove any discomfort, or to discomfort the patient until the same obsessions do not cause any fear, and challenge the patient to basically live with uncertainty, because that's what they need to eventually learn. In terms of for pharmacotherapies for obsessive compulsive disorder, you want to use SSRIs after they've failed the psychological therapy. And hospitalization, especially for those with a very high suicide risk or have symptoms that impair their ability to self-care. Thank you so much for watching this presentation. I hope it was useful.